Good morning, everyone. I'm presenting on tackling pediatric orbital floor fracture when less is more. Pediatric orbital floor fractures have unique mechanistic and healing patterns, but still are managed with adult fracture guidelines. Our aim was to compare final outcome between non-surgical and surgical management of orbital floor fractures in pediatric age group, and to propose a possible management protocol in pediatric floor fracture based on clinical features. A total of 38 patients aged less than 18 years with pure orbital floor fractures were included. Their signs, symptoms, ocular evaluation, diplopia charting, in-ophthalmos measurement, HES charting was done. CT scan was done to look for fracture type, site, muscle, and or soft tissue entrapment. And we divided pediatric blower fractures are divided based on CT findings as group A, trapdoor fracture, group B, floor fracture with incarceration, group C as depressed floor fracture. And group A, trapdoor fractures which needed immediate surgery via transconjunctival approach. And group B and C are non-trapdoor fracture. If there is gross motility restriction of -3 or -4 and it needed immediate surgery. If there is mild or nil in restriction with or without diplopia or in-ophthalmos, it needed conservative management. Criteria for success we considered as nil diplopia in primary gaze, in-ophthalmos of less than 2 millimeters, no hypoglobus, EOM restriction of less than 5 degree in upgaze but normal in other gazes. Coming to results, a total of 38 patients, 31 were males and 7 were females. Mean age was 12.4 years, and 50% was due to 50% were due to sports injury, and least was due to motor vehicle accident. Group A, trapdoor fractures. Total of 7 patients had trapdoor fracture. Among that, 5 patients had white-eyed blower fracture, and because one patient had residual 10-degree upgaze restriction, so 6 out of 7 were successful. And floor fracture with the incarcerated tissue, total of 19 patients, 16 were conservatively managed, but because of the non-resolving primary gaze diplopia, 2 had to be surgically managed, and other 3 patients were surgically managed. 5 out of 5 were successful. And group C, depressed floor fracture, total of 12 patients, 10 were conservatively managed and 2 were surgically managed along with those 3 of conservative group, as 1 had non-resolving primary gaze diplopia and 2 had significant hypoglobus. 4 out of 5 were successful. 1 had residual 10 prism diopter upgaze restriction. And coming to discussion, pediatric trapdoor fractures, including white-eyed blower fracture, warrant immediate surgical repair to prevent sequelae of oculocardiac reflex and muscle fibrosis. And optimal management of non-trapdoor fracture remain controversial, but non-trapdoor fracture with mild or nil movement restriction, we can wait and watch. And at 2 weeks of follow-up, if there is no diplopia, we can wait and watch. And at 4 to 6 weeks, if there is persistent primary gaze diplopia, surgery is needed. And in case of if there is in-ophthalmos at 4 to 6 weeks of follow-up, if it is noticeable, and surgery depends on decision of parents. We concluded that considering the risk of orbital surgery, risk of anesthesia, non-trapdoor pediatric fracture, surgery can be delayed till edema and inflammation resolves. Surgery only if clinically significant diplopia or noticeable in-ophthalmos is there, and surgery if decided to be done, then a simple transconjunctival incision over a cutaneous incision was sufficient. Thank you.
How many days or years these many patients you could gather? 38 patients.
Over 6 years.
Over 6 years.
Yes.
What your study is adding to the existing literature?
So we thought we can manage conservatively for those who didn't have gross extraocular motility restriction. So we can wait and watch. Even if some patients were not bothered about in-ophthalmos, we can wait and watch.
Why does in-ophthalmos happen?
Sorry?
Why does in-ophthalmos happen?
Immediately after injury also we could see in-ophthalmos.
Madam is asking, what is the cause of in-ophthalmos in these blood fractures?
Because of the extra fat tissue prolapse or...
Where?
Because of the counter coup injury, hydraulic pressure, the orbital trap would have trapped into the extraorbital tissues.
Wherein it prolapses? Why not any other? Why not medially?
Medially,
Yes.
because of the bone.
Inferior also there is a bone. Okay. What are the problems with intervening surgically?
In pediatric age group, these are pediatric patients, sir. Considering the risk of anesthesia and growing bone in the children, so in some cases we can wait and watch.
Anything else? Any other surgical problem? Okay.
What are the indications of surgery and how long do you wait for it?
For some patients, we waited for 12 weeks, ma'am, 12 to 24 weeks. If
What type of
there
patients?
is, in case of non-trapdoor fractures, ma'am, if there is no muscle entrapment and if there is no gross motility restriction, we just maintain them on anti-inflammatory and all.
No, when there is entrapment, how long do you wait?
If there is significant entrapment, in immediate surgery.
What do you
or
mean by
immediate-
significant entrapment?
forced duction, gross motility restriction of -3 or -4, and the forced duction test was positive. So,
So, what is the indication of immediate repair?
in case of white-eyed blood fracture, there is no significant ecchymosis or no external signs, but still patient will be having bradycardia or other signs, and
What are the other signs?
bradycardia, syncope, and other vitals.
For immediate repair, you have to see the go for the symptoms like nausea, vomiting, bradycardia. So you have to plan the surgery immediately. Otherwise, you can wait for it. And what is the difference in the fractures between the children below 7 years and above? More smaller children? What type of fracture is common?
In smaller children, medial orbital fractures are more common. In adults and all, floor fractures are common.
I think it's not that way.